Our guest today is Executive Vice President, Strategic Affiliations, and Associate Dean of Community-Based Research at the University of Chicago Medical Center. He is responsible for leading the medical center's urban health initiative, linking the medical center's mission of patient care, teaching, and research for the purpose of improving the health of South Side residents. Until October 2007, our guest today served as the director of the Illinois Department of Health. He is a native of Chicago and received his undergraduate degree in chemistry from Grinnell University in 1987. Our guest today earned his master's degree in public health from the Harvard School of Public Health in 1991 and his medical degree from the University of Chicago in 1993. Ladies and gentlemen, please welcome back to the City Club of Chicago, Dr. Eric Whitaker. Eric? Thank you. Have some fun up here.
I have to always see what time it is. Good afternoon. First of all, I want to thank Jay for that introduction. It is exciting to be back here at the City Club, and I think I actually had a gap of a year where I actually paid for membership. So that's one way to keep membership is keep speaking. And I also want to thank the many friends that are here. As I look across the room, I see folks who went to grade school with me, really, as well as many others. And as I start this afternoon, I would be remiss if I didn't recognize a few of the guests that are here with us. So first of all, I would like to give a shout out to members of the Southside Healthcare Collaborative. By show of hands, these are some of the partners that are engaged in the work we're talking about relative to creating a system on the south side of Chicago. Also would like to recognize those who are from the University of Chicago Medical Center by show of hands. As mentioned, Jim Crown, who's our board chair, as well as Dr. James Madera, who's the medical center dean and CEO, is here. And I certainly would be not able to go home tonight if I didn't recognize my wife, Dr. Cheryl Whitaker. and I won't say that it's, she never comes to hear me speak. It's a rare event when she sits in an office to hear me, I'm in an audience to hear me, so I want to thank her for coming. She's joined by a number of friends, including my pastor, Otis Moss, from a church you've never heard of, Trinity United Church of Christ. As well as his wife and his parents. And again, we want to thank them for joining us. So thank you for that small indulgence. So it's been about 2 years since the last time I stood before you. And at that time, the topic that I shared with this audience was around pandemic influenza. How many of y'all remember that topic? It's still out there. I know I see the commissioners of health for the city, the state, as well as the county all in the audience. And they would want you to know that it's still an important issue. It hasn't arrived on our shores yet, but it's coming, so you better be prepared. So, as you know, a lot has happened in that intervening time from 2 years ago, including Barack Obama, who is a friend of many of us in this audience, competed for and won the U.S. presidency. Also, Illinois has been in the audience for some less favorable things relative to our politics. Despite what your sentiment is about our political leadership nationally and locally, I firmly believe we are at a dawn of a new era of civic and political engagement that will help our country tackle issues around which we have nibbled around the edges. And these are things like health care, things like climate change, and even the thorny issue of comprehensive immigration reform. If this sounds like the Obama agenda, I will plead guilty to having drank the Obama Kool-Aid a long time ago, and even some say I swim in it daily. As you may know, I met the president while playing pickup basketball with him, like in 1990, when we were both graduate students at Harvard. And I often get asked, what kind of player is he, as does our friend Marty Nesbitt, who is sitting to my right. And as Marty knows, he's tough, he's a competitor, and it may not surprise you that he doesn't like to lose. But here's a problem for me. He scores a lot more than he used to. With all those Secret Service agents packing firepower around him, you just can't foul him like you could in the old days. But I have to tell you, it's still fun to get out on the court with him regularly. And though I have to say that ibuprofen is also more in evidence than it used to be. Now, quiet as it's kept, if you read the papers, you wouldn't know that I actually had a day job. I actually have a day job, as Jay mentioned, as Executive Vice President at the University of Chicago Medical Center. And based on what many of you probably read in the press recently, you're wondering what the heck is going down in Hyde Park. We have been the subject of articles in the Wall Street Journal, the Chicago Tribune, the Sun-Times, the Washington Post. We've even been on Rush Limbaugh, and you know that can't be a good thing, right? And anyway, I'm going to spend a short amount of time just trying to give you a sense of what's happening down in Hyde Park and what we're trying to accomplish. At the University of Chicago Medical Center, we are grappling locally with many of the problems that animate the national policy debate regarding health care, including that troika of access, quality, and cost. I don't need to tell many folks in this room that our national health care system is broken. But let's be clear. The University of Chicago Medical Center is not alone in its problems, issues, and challenges. Nearly every hospital in the country has experienced the same environment. If you look at the numbers, over 47 million people are without insurance. In Cook County alone, that's about 785,000 people. Even those with health insurance, 25 million find that their insurance doesn't cover their medical expenses. And these are folks who are called underinsureds. So if you look at the totality of it, over 70 million Americans have no insurance or inadequate health insurance in this country. And even prior to the financial meltdown that we're experiencing nationally, 50% of all bankruptcies were attributed to medical expenses. So when you look at this situation and we start talking about the emergency room, our country's emergency rooms are used inappropriately for non-urgent cares, while options for care called community health centers or federally qualified health centers that can provide a medical home for patients are underutilized and unknown. In fact, it's been just over a year ago that we did a survey of 600 Southside residents and found out that 64% of them didn't know that these community health centers existed as an option for care. And these are the folks who show up in our emergency room and constitute about 40% of the visits that come to our emergency department. So when you hear the term health system, it's a misnomer. We don't have a system of care, but rather a great duplication of effort and waste as hospitals with scarce means are competing with one another. And I haven't even touched on the fact that there's not as many primary care and subspecialists plying their trades in certain parts of the city as others, in communities that have great disease burdens. So again, our healthcare system is broken. Let me give you a little more local context. On the south side, we have seen 6 hospitals close since 1986. And as Jay mentioned, I started medical school in 1987. So since that time, we had Woodlawn Hospital that closed in 1986, Provident Hospital closed in 1987, which, as you all know, got reopened in 1993 as a part of the Cook County Health System. The Hospital of Inglewood closed in 1988. Chicago Osteopathic closed in 1996, and if you've been along 53rd Street, you know they're condos now. Doctors Hospital of Hyde Park closed in 2000 and is a site for a proposed hotel. And soon Michael Reese Hospital will join the group, and it's to be the proposed home for the Olympic Village if we get the Olympics in 2016. That's 6 hospitals in 2 decades. We at the University of Chicago like to believe that we're data-oriented. And when we look at this data, it says to us that hospitals need a new strategy. In fact, in business, there's a term called co-opetition, which means that competitors work with each other on projects project to project for joint ventures. And perhaps we need to take a serious look at that sort of partnership where we are competitors, but we work together. And this is, again, in terms of context, there's a great amount of disease burden on the South Side. It's incredibly high. The hospitalization rate on the South Side for common diseases like diabetes, hypertension, congestive heart failure are 2 to 2.5 times that for the rest of Illinois. And so when people go to the hospital, these are typically for conditions. If we can get them appropriate primary care in the community, we can prevent those ER visits and hospitalizations from ever occurring. And we at the University of Chicago provide more care to poor and uninsured people than any other private, nonprofit hospital in Illinois, any other one. So despite this fact, we only take care of 10% of the patients on the South Side of Chicago. So it's important that we work together to care about what happens to the other 90% that don't show up at our door, that we work together to ensure quality across all of these various institutions. You know, I have to tell you, I've been particularly stung by the slow demise of Michael Reese Hospital. It's a hospital where my mom trained as a nurse at a time when African-American women could only be trained at Cook County Hospital and Michael Reese. My two brothers and I were both, my two brothers and myself, we were all born at Michael Reese Hospital. In fact, my first job was at Michael Reese as a doorman. So I got good money back in those days. It was actually $15 an hour back in 1984. That's still good money today, right? And that might be why they're not here, too. I used to work my 20 hours a day, 20 hours a week rather, as a junior in high school, and that was good money then and now. And Michael Reese has a storied place in history as being important for, you all are familiar with cholesterol being important in heart disease. A lot of that fundamental work was done at Michael Reese Hospital. The bassinets to take care of kids in neonatal intensive care units, that was done at Michael Reese Hospital. The EKG was perfected at Michael Reese Hospital. Michael Reese had a storied history in the annals of medical science, and we drove by there just recently and it looked like all the lights were out. And it's a sad thing, and I dreamed of one day practicing medicine there, and that's not to be. But even if you get beyond the healthcare part of hospitals, during my time at the state as the health director, I came to understand hospitals as economic engines. In fact, the U of C Medical Center is the largest employer on the south side of Chicago. And if you look throughout the state of Illinois, if a hospital closes, a town has difficulty attracting new business to come there because any employer that will relocate wants to know where their employee is going to be seen. And also the healthcare sector has been recession resistant, if not recession proof. We used to be recession proof until this latest recession that we're going through right now. So the health of hospitals is important to the health of communities. Well, it's with this backdrop upon which the University of Chicago Medical Center started the Urban Health Initiative, or UHI. The idea is to extend the medical center's mission of patient care, teaching, and research out into the community, and in conjunction with community leaders and organizations, craft solutions that will improve the health of Southside communities. So let me take you through each of these missions in turn and speak to some of the things we're attempting to do with the Urban Health Initiative. So in the realm of patient care, we're partnering with the community health centers. I asked my partners to raise their hand a short time ago, as well as hospitals to create an affiliated system of care that builds on the strength of our partners. That is, our community health center partners are great at primary care and as well as preventive services. The University of Chicago sweet spot is actually doing tertiary and quaternary care. So the thing we want to do is to do those things that won't be duplicated by others. And we've also partnered with some hospitals, including Mercy, and most recently with Holy Cross. This collection of community clinics have come together into something called the Southside Healthcare Collaborative. And one project that we're working on is the establishment of medical homes for all of our patients. And medical homes are important because evidence suggests that patients with a medical home get more accurate and earlier diagnosis of problems. They use the ED less. They have fewer hospitalizations. They have lower costs, better prevention, fewer prescription drugs, and increased satisfaction. All sounds like good things to me, and what we should be seeking. But one point that needs to be made as we talk about the emergency room, regardless if you have platinum insurance, gold insurance, silver insurance, or no insurance, you should not use the ED as a place to get primary health care. Should not happen. And in our emergency room, we believe that, and regardless of payer status, we think you should be in another setting if you have a non-urgent condition. And that's what we're working towards with the Urban Health Initiative. We're trying to create this system without U of C owning everyone. We're trying to improve the health of community residents by preventing problems before they begin. And if one gets a problem like diabetes or congestive heart disease, we try and manage that condition so that urgent care is less needed. And to date, we have more than 50 U of C doctors who are providing health at healthcare centers and hospitals on the south side of Chicago. We have a relationship with Mercy Hospital for inpatient psychiatric care, as well as for inpatient general care for internal medicine. And as I mentioned a week ago, we started a program establishing a Center for Excellence regarding inpatient geriatric patients at Holy Cross. And that affiliation will grow in scope as time goes on to other areas of excellence. We also have a longstanding relationship for subspecialty pediatric services at La Rabida Hospital. Our partnerships allow us to focus on conditions that need a high-tech platform at U of C while putting community hospitals and while using the best of community hospitals and community health centers at their best and highest use. On the outpatient side, in addition to the primary care work we've been undertaking with the Southside Healthcare Collaborative, we've also begun the development of a new subspecialty community-based practice at Access Grand Boulevard, a site where we've actually invested money and doubled the capacity of rooms right at 55th and the Dan Ryan. We also have a relationship with Stroger Hospital for pediatric specialty outpatients, which has been a phenomenal experience for both of us. At Stroger, they have capacity for pediatric subspecialty. We have a lot of patients. We match up supply with demand, and it's a win-win situation. So, you know, we've been in the paper a great deal, and you know, I was waiting with bated breath. You know, we knew that the Chicago Sun-Times was writing, Chicago Tribune was writing an editorial about our efforts, and we didn't know how it would play out. We certainly believe we're doing the right thing, and we were happy when the Trib concurred with us and said that the university, via its Urban Health Initiative, isn't forsaking patients. It's caring for many of them by providing funding and staffing for the clinics to help ease its ER patient loads. It may also refer patients to other reputable hospitals for follow-up care. This is a smart move and could be a model for other emergency rooms across the country. And that's one, in terms of the patient care aspect of the Urban Health Initiative, we're trying to create models that can be replicated throughout the country, because that's what we do, generate new knowledge that can be used around the country, if not the world. And it's also our hope to continue to expand participation from other community health centers and clinics. And this can only be done if there are win-wins as we do this. So as I mentioned, the Urban Health Initiative, a lot of attention gets paid to the patient care aspect. We also think it's important to talk about teaching as a part of the academic mission. And our charge is to expose our students and residents to opportunities to learn through community-based experience. And to date, most of the experiences that our students have are on campus. And so students really have no concept of what's out there in the community for them. And as a result, when our students and trainees finish their work, they end up leaving the city of Chicago or go elsewhere to practice, when in fact we want our students and trainees to stay in the neighborhood, have robust academic careers, and be a part of the network that we're trying to build. And this is important for two reasons. First of all, again, we want people to stay on the South Side and improve the quantity and quality of the resources that our community residents have access to. But secondly, our medical school is the fourth leading institution behind this place called Harvard and others med schools in the country for the production of academic physicians. And these are doctors who become teachers of doctors. So if we do a great job in terms of exposing our students and residents to community experiences that are impactful, these folks will leave and become faculty for other medical schools and propagate the things that they learn on the South Side of Chicago. And we think that's pretty important to do that right. Also, we have just restructured our medical curriculum to, for the first time, include community scholarship, as well as community service learning and research. So we, again, are putting our money where our mouth is in terms of our curriculum. And lastly, many of you all may not know, but educational debt plays a role in how students end up deciding how to practice. And we started a program where we will pay for our students and residents' loans who practice in our network on the South Side up to $40,000 per year for 4 years. So for a total of $160,000. If they will stay and practice on the South Side within our network. And that's important because most programs are targeted at primary care, but we do this for both primary care and subspecialty care. And then the last part of the academic mission is research. And again, I believe in the power of data and the power of research. On the South Side, it could be a tough sell, though, because our surrounding neighborhoods have a distrust of researchers and a general lack of impact that's seen from having the research done. And the general consensus is the data is collected, and then the community participants in the research never hear from those researchers again. And I have to tell you, I practice out in the community, and I have that very same sense, that people come get the data and they jet out and you never hear from them again. And that was my experience in Woodlawn. That data would be collected, someone would write a paper, they would get published and get promoted, but really there was no benefit for the community for participating in the research. On the other hand, we need data. We need data to better understand what impacts health positively or negatively. We need data for needs assessment. We need data to design programs that respond to the urgent needs of the community. We need data to understand whether or not any program or initiative we may undertake actually works. If we have data, we can make the case for local as well as national policy changes. For all these reasons, we need data. Well, in the spirit of the Urban Health Initiative, we've established something called the Southside Health and Vitality Study, which is a large effort in conjunction with the community to collect data that's meaningful. And this study is laying the foundation to collect elaborate data on 33 community areas so we can understand what is impacting health positively or negative. With that knowledge, we can then take steps with community leaders to positively affect health status. Over time, we can better understand any interventions we undertake. And if things work, we should scale it up. And if they don't, we need to find a different solution. And I just want to give you an example how this might play out on a local level with some work I did when I was at the state. And just several years ago, Steve Whitman, who used to be the chief epidemiologist for the city of Chicago, came to the Illinois Department of Public Health to see me. And he and his team found from some data that on the west side that there were a lot of ED visits and hospitalizations for asthma, a condition that if you have appropriate primary care, you can keep people out of the ED and out of the hospital. He then hired community members to man the emergency room when these patients with asthma would show up. And this lay health worker would then go to the home of patients after having pre-established a relationship in the ED. They would go to the home, look for triggers for asthma attacks, and also help the parent and the child learn how to use those metered dose inhalers, those puffers. And as a result of this low-cost intervention, asthma visits in the ED and asthma hospitalizations plummeted. They dropped precipitously. And patients had better outcomes, And money that has been spent in the ED and on hospital admissions is now saved for better uses than to take care of patients who could be taken care of elsewhere. I was really blown away by that data, and I asked the epidemiologists who work for us at IDPH to go into all of the data that we have for the state and find the 10 counties that had the worst prevalence of asthma. And with that data, we ended up taking Steve's model and taking Steve and training lay health workers in 60 hospitals in those 10 areas. And that way we scaled it up and we got a favorable impact, lowering hospitalizations, keeping people out of hospitals, and keeping them out of the emergency room. That's what public health is about, and that's the sort of thing we're trying to do on a local level with good data. Given that experience, and I should say that we've been able to move forward with the support of a lot of community-based organizations and political leadership because they understand how if we have data that's actionable, we can have an impact by then developing interventions and translating that into programs and evaluating if those programs work. So we are in the midst of creating a study and look forward to moving forward with that. As we've tried to put together the Urban Health Initiative, I've come to believe a few things. First, and I think this has some import for as we look at healthcare reform at the national level. First, financing insurance for everyone is not going to be sufficient. It's going to be, we need to do more than that. In fact, we need to develop true systems of care. Often we can expand insurance to populations, say with kids, like with all kids, probably 90 to 95% of kids are covered. But if individuals don't take that insurance, we won't have any better impact just because they have an insurance card. So we really need to think about how access plays out despite having insurance for everyone. Secondly, academic health centers can't be all things to all people. It can't be both a tertiary and quaternary center as well as a community hospital. And we need to be good stewards of the scarce things that only we can do at a place like University of Chicago. Robotic surgery or exotic transplants don't and shouldn't happen at every hospital. But for those that do it, we should focus efforts at those. A corollary to that is we have to be responsible for training the next generations of physicians and leaders in the field of medicine. And we need to have students and residents who are going to be those leaders have the most cutting edge of experiences so they can propagate that throughout the country. Patients should be seen at the right place and the right time given those two things. And lastly, and this seems to be controversial, emergency rooms should be used for emergencies. I'm shocked that we get in a debate about this. In fact, there was an article in the Trib a couple of days ago. An ER doc was essentially saying that if someone comes in for an emergent condition, it's okay if we use the emergency room as a doctor's office. And I start screaming at the paper, like, no, it's not. That, in fact, an ED visit is $1,000. A doctor's visit is $100 out in the community. And one of the things we need to be clear on, this is not some abstract money. This is your money. If you have insurance, you're cross-subsidizing those who are in the emergency room without insurance. And if you're not paying that way, you're paying through taxes. This is our money. So we have to be good stewards of that money to make sure we can get the most people covered in the best and highest use of that money. We all pay for the misallocation of resources. And lastly, we need to recognize that to create healthy communities, healthcare is but one piece of the puzzle. Other social determinants of health like economic development, education, physical environment, and public safety may play an even bigger role in making communities healthier than building another clinic. And I just remember talking to one of my patients. We started a Black Men's Clinic, and I was talking to this patient. I asked him about his health, and he said, "Doc, the best thing you can do for my health is to get me a job." And I trained at the University of Chicago. I decided to go to the literature and see what it said. And in fact, he was true. Even beyond having a job that has health insurance, there's a salutary effect, a positive effect from being employed. That person contributes positively to their family. There's a lot of great things about that. So at our Black Men's Clinic, we started doing economic development, which doesn't seem to be in the mandate of a community health center. But if you care about improving the health of a community, you do that sort of thing. So in that spirit, out of the University of Chicago, we will have in the community a Center for Community Health and Vitality. Its sole purpose will be to think about community benefit. How do we take the research we have and translate it so it has an actual benefit to the community? How do we make sure that the pipeline programs that we have that are trying to take youth in the community and make them doctors or researchers, how do we make sure that people know they exist? A lot of times, if you have a good information network, you get into those programs, but the broader community doesn't know about it. This Center for Community Health, we just hired a director a couple months ago, and she's going to do a phenomenal job of doing that translation. So again, to make a community healthy, it takes more than just having a clinic. And as I close out, I just want to say that, in this country, we've made a lot of progress in terms of health. We spend the most money of any country in the world, bar none. We are not getting the benefit for all the money that we spend. So we have a great deal of work to do. One of my closest friends has just been elected President of the United States. And we've talked about this issue for some time. The sorts of issues related to community health centers, if you've noticed, has been on his radar screen. And it's something we feel passionately about on the south side of Chicago. I'm looking forward to improving health on the south side of Chicago in the communities that have birthed me and nurtured me. And I'm looking forward to working with many of you all in this room to take the things that we learned on the south side, on the west side, and taking that national. So, I just want to put out the challenge that I need your help. The president needs your help. We all are in this together, and I'm looking forward to working with all of you all to finish the work that we've started. Thank you.
All right. By the way, we do have questions. We forgot to mention it. Not that talk was controversial. We do have on your table the official question form. Teresa's over there. Don't escape. And if you raise your hand, she'll pick the question and we'll ask it to Dr. Whitaker. And for the record, I, too, was born at Michael Reese Hospital, as were my children. Okay, here we go. By the way, as always with Professor Green, legibility is the equal to clout. So, Iceman, it's a long time since we had class together. Here we go. From David Blowers from Northern Trust. Can you talk about the strategic implications of the affiliation with Evanston, Highland Park, and Glenbrook hospitals?
Okay. Yes. So for those, just by way of background, we started an affiliation with what it's now called North Shore University. Am I getting this right? It's a North Shore. And the strategic implications of it are that there's some things that we can't do on the south side of Chicago in terms of education. And I should back up and say that we started this affiliation within the last year. And it's around the academic mission of North Shore as it relates to the south side. We've not expanded it much beyond that at this point. But, for the things that I'm doing, the things that's exciting is that North Shore has put aside, I think, $15 million over the next 5 years to do an urban health initiative-like effort in Lake County that will happen over the next 5 years. And that's exciting because we have a predominantly African-American community on the south side of Chicago. Lake County, the population that we'll be working with is largely Latino. And as a consequence, as we try to develop models on the south side, we can try those models up north to make sure that it works in different populations. So, from my perspective, that's the exciting part of the strategic implications. The important point to make is that resources from the south side won't be drained from the south side to go north, and the south side somehow be left holding the bag from those affiliations.
This is from Dave Lundy, who did not pass the, no offense, the writability here. I'll just read the first part. Do you believe a mandate is required for health care reform to be effective? If so, what type? I know it's hard to read, I understand.
Oh, so he also asked, how was the Seder?
I thought I'd leave that out.
Okay.
I thought you covered that.
Yeah. Well, I didn't comment on the Seder. That was my second Seder in my life. And I should say the Seder that we participated in on last Thursday was an anniversary Seder because the president and some young staffers were having a Passover meal. We had it while we were traveling on the road last year for the presidential campaign. And as many of y'all know, at the end of the traditional Seder, you said next year in Jerusalem, and the president lifted his glass and said next year in the White House. And as a consequence, we ended up meeting in the White House. So it was a great experience. And the mandate issue is a hard one, though. I think we may end up having one. The challenge is even if you mandate it doesn't mean it will be so. So in a very real way, I don't believe in mandates as a general rule, but I think to try and make sure that everyone gets in the boat, we may have to request one with the knowledge that it probably won't work anyway.
This next question is from my congressman, Danny Davis. How important are community health centers to national health reform?
Congressman Davis, I call Congressman Davis, even though I have Congressman Jesse Jackson, I call Congressman Davis my congressman, so he's one of my congressmen also. Community health centers, I think, are critically important in the healthcare mix. In terms of the business model, as I understand it from the Illinois Primary Health Care folks, the people who are the Association for Healthcare for the state of Illinois, they talk about the business model for FQHCs being able to accommodate up to 20 or 30% uninsured in their model, as well as a great deal of Medicaid and Medicare, and as well as private. In fact, in New York State, they actually, the FQHCs are really trying to push into the private market. And one of the things I want to make a point, just bridging off of this, is that community health centers are for anyone who needs health care. It's not just for poor people. And in fact, if you go to the centers that are part of our network on the south side, CoMed, I see Bernice Thomas Mills, you've all won architectural awards for their buildings. The same is true of Access Clinics. The clinics, the community health centers are beautiful. And I think that and I actually don't even like to use the word clinic because people get they get a thought in their mind about what it is. And community health centers are beautiful places. So I think community health centers are a cornerstone of preventive services. The challenge we have and that we're trying to work through is how do we take the subspecialty-based services we have in our hospital and move that out to a community base. And that's what we're trying to work through right now to develop a model with at the Access Grand Boulevard.
Oh, late returns. God, I feel like I'm in Lake County, Indiana. All right. Little political humor there, just little political humor. That primary, the vote's still coming in.
Yeah. It was electronically counted also.
Yeah, and so. I was there 40 years ago. Nothing changed. Okay. From Governor Topinka. There you are, Governor. Sun Times writes UC Hospital stabilizing patient
from the ER.
From the
and
ER,
then
allegedly dumping them on Stroger Hospital.
Yeah.
Comment.
Yeah, we don't think that's accurate. Where are you? Yeah, we don't think that's accurate. And let me explain specifically what we're in the midst of trying to change. Right now, if you come in our emergency room, you get a triage into a variety of colors or numbers depending on the system. And in our system, blue greens are non-urgent, sort of conditions. And if you end up coming in currently, you get triaged, and then you sit and wait for a medical assessment whenever that comes. And because you're a low acuity patient, you get bumped and bumped and bumped and bumped and sit in our ED for hours upon hours. What we're trying to do right now is to move the medical screening from a distant time from when the patient gets there to assess whether or not after they get triaged they need to get care in our emergency room, or can they get seen down the street at a community health center the same day or later, or even for problems that can be seen at others of our partners much later. And this is a different way of doing things, but this is happening at Parkland Hospital, a public hospital, just implemented this system probably about 3 months ago. The reality is we can't continue what we're doing currently. It's unsustainable. It doesn't, not only is it unsustainable from a financial sense, it doesn't get good outcomes for the patients themselves. So we're trying to partner with folks where we can make an appointment for them the same day or in the near term, and not have them sit in our ER where they draw resources away from people who have more acute needs. And again, people think that's controversial. It seems to me to be common sense.
Well, that'll be the last question. Dr. Whitaker, as a former UFCer, I want to see him get back to work.
Oh, yeah.
Oh, this will be the last question. This one, this is a short story. Okay, this is from take it well to read.
Okay.
Stanley Hill. How is the UFC leveraging information technology to collect, manage, analyze, and share data with its partners and affiliates?
Okay. And, as you know, as part of the stimulus, there's a great amount of money that's being set aside for electronic health records and other IT needs, as much as $20 billion. And so we're in the midst of working together with the Southside Healthcare Collaborative to do planning for how to connect everyone by electronic health records and other technology. We also are reaching out to donors who have interest in the IT arena. So if any of you all are here and have a spare million or so that you'd like to contribute to this process, please let us know. But we're working to connect everyone on the South Side with electronic health records. We believe that it'll increase quality, for our patients. Right now, you may have a child get immunizations 3 or 4 times, all because people don't have a record. There's a cost to that from a health standpoint as well as a financial standpoint. And also, it will help us, as we look at emergency room issues where, there are individuals who go from emergency room to emergency room, and you get tests repeated over and over again. If we could draw the results of the test without having to repeat it again, we can save more costs to the system.
Very short question from Hans. Was that Longroth? Not a member of the City Club, that's why I have trouble pronouncing the name. What types of mental health services are involved with this program?
Yeah, that's an issue that we still have yet to address. I mentioned the Southside Health and Vitality Study. One aspect of it is looking at mental health issues. We think that health needs to be holistic, not only physical health, mental health, oral health, to make a difference in the lives of others. And in fact, we've done, through the Southside Health and Vitality Study, maps of available mental health services on the South Side and the West Side, and I have to tell you, they're very poor. There aren't a lot of services, and in fact, we were brainstorming about some ways that we could get clinical social workers into federally qualified health centers to help improve access to not the sort of mental health needs for profound mental illness, but for more short-term interventions.
Last question is from Mo Headington. I think you started something, Doc. Another Michael Reese birth.
Yeah.
If you weren't born to Michael Reese in this room, boy, you're really at a disadvantage. I am an environmental activist focused on air quality issues that impact heart and lung disease. It would be invaluable to have the support of the medical community. What role can the UFC play in
Program prevention?
Yeah.
So, again, the Southside Health and Vitality Study has a number of different elements to it. One very important element is that we've engaged Argonne National Laboratory to start keeping an assessment of air quality. As you all may or may not know, the South Side of Chicago has areas that are called asthma death zones. That is, places that, we have a serious disparity of asthma deaths for kids on the South Side. And by tracking air quality, we can look at how to intervene from a policy perspective. So again, data will be critical in being able to figure out what's happening now and 5 years into the future, knowing what's going on. So if there are changes that are negative, we can work with the community partners to make a difference.
We got gifts, parting gifts.
Okay.
Dr. Whitaker, another City Club mug. I'm sure you'll find that useful.
I like bookends.
History of the City Club. I'm sure the president would really, since he's not doing much reading, maybe cut up with that. A one-year paid membership to the City Club. And let me just simply say that if he finds time to come back here, the City Club might find room to have the president give a speech. I mean, JR, you know, we're pretty well booked up, but we might squeeze him in. Adjourned.
Thank you. Thanks a lot. Thank you, sir.